Thank you, everyone. Good morning, everyone. I hope you had a good session. So this is Dr. Rajas Aftab. I'll be taking care of this next session. Our next speaker is Associate Professor Dr. Baharudin Ibrahim, who has obtained his Bachelor's of Pharmacy in 2005 and Master's in Pharmacy in 2007 from USM, Malaysia. His PhD work was on metabolomics and respiratory medicine from University of Manchester, 2011. He has presented many of his research work in international conferences and has published his research in reputed journals. He is also the Master's Clinical Pharmacy Coordinator and Chairperson of a Clinical Pharmacy Program at USM. Dr. Bahar is actually working as an Associate Professor in Clinical Pharmacy and specializing in respiratory medicine and infectious diseases at University of Malaya right now. He is also the Deputy Dean of Student Affairs. His research focuses on precision medicine, omics, to identify the biomarkers of disease and metabolites or genes to predict drug efficacy in ATRs. So without further delay, I leave the floor to Professor Bahar. Professor Bahar, the floor is yours.
All right. Thank you very much, Dr. Raja, for your kind introduction. Assalamu alaikum and good morning, everyone. Thanks to the organizing committee, to the organizer for the opportunity. First time I'm actually seeing all of you. I'm quite new to UM, so nice to meet all of you. And today's talk, my talk would be a bit similar with Dr. Fu. I think we share the same passion on precision medicine, but I'll be focusing more on the drugs. Of course, I also do biomarkers for diseases, but for today's talk, I will focus more on the drug that we have done. I would like to acknowledge my PhD student because it's her work, not my work. She did the slide also for me, Miss Arwa. So she has completed her PhD. So this research is about Clopidogrel. Just now Dr. Fu was talking about oncology. So now I'm talking about cardiovascular, but the drug that is used in cardiovascular, which is Clopidogrel. At the moment, whenever we give a treatment to the patient, we always want to monitor how the effect is. But for this particular drug, Clopidogrel, there is no proper testing mechanism at the moment available. Okay, of course, there are a few methods you can use, but not really practiced in the clinical. So so the purpose of this research is we want to find what other mechanisms we can use to monitor the Clopidogrel treatment. The title is too long, so I don't want to read it. So basically, this is just a brief introduction about Clopidogrel. It's a second generation tyrosine. It's an antiplatelet, P2Y12 antagonist, crucial for patients undergoing PCI, percutaneous coronary intervention, in the dual antiplatelet therapy. So usually they will give together with aspirin to prevent myocardial infarction or stroke. I hope my slide is moving. Okay. So just a bit introduction about Clopidogrel. So 50 to 40% are hypo-responsive to Clopidogrel. That means after you give the drug, okay, Clopidogrel is meant to reduce the platelet activity. Okay, but for some patients, about 50 to 40%, even after you give the Clopidogrel, they still have high on therapy platelet reactivity. That means when you give the drug, their platelet is still active. Okay. One of the reasons is due to genetics. Okay, so I'm not going to look at the genetics like what Dr. Fu has been looking at. Mine is more on the SNP type, okay, a single nucleotide polymorphism. Okay, so we have found that there are enzymes which are related to P2Y12 receptors, or they may affect the Clopidogrel treatment. So I will come back to this when I present the results. So what will happen when patients have different polymorphisms on that SNPs? They will have poor therapeutic outcomes, which will lead to stent thrombosis or recurrence of ischemic events. And there are also other aspects which can also lead to clopidogrel non-responsive, such as diabetes, drug interaction, poor compliance, okay. So there are many factors. I'm not going to discuss about other factors. I'm going to focus mainly on the genetic and metabolomic factors. Okay, so how clopidogrel works is, clopidogrels need to be activated. Okay, clopidogrel, when we take the clopidogrel, is actually a prodrug. So for it to have effect, it has to be biotransformed into an active form. Okay, so there are two parts of metabolism. Okay, and this involves enzymes known as cytochrome P450. Okay, CYP450. So for today's discussion, I'm only going to focus on CYP2C19, star 2 and star 3 alleles. Okay, this enzyme need to activate the clopidogrel, need to metabolize the clopidogrel to a bioactive form. So when you have, okay, so there are wild type, which is most of the people will have, and then there's also variant type. Okay, so there may be a different allele or variant which have changed, the nucleotide has been changed, which cause this enzyme to have less activity. So it won't fully metabolize the clopidogrel to an active form. So when clopidogrel is not active, then the effect will be less compared to the fully activated clopidogrel. So that is what we are actually looking at for this research. So there's wild type, so normal enzymatic activity. So there are heterozygous type. There's star 1, there's star 1, star 2, there are star 1, star 3. Okay, so we are looking at if there's heterozygous, that means one is star 1, one is star 2, or one is star 1, one is star 3. Then you may have intermediate enzyme activity. Okay, but you have a homozygous mutations. Okay, both are mutated variant. Star 1, star 2, star 2, or star 3, star 3, then you have poor enzymatic activity, which means the clopidogrel won't be fully metabolized to active form. So that means clopidogrel cannot have its full effect. So FDA suggested genotyping of CYP2C19 to predict clopidogrel. So FDA has already suggested to actually genotype the CYP2C19 to assess the clopidogrel efficacy. So in this study, we want to see whether is it the best method, or we can use other methods such as the metabolomics to better predict the clopidogrel response. Okay, sorry, this thing is blocking the slide. Okay, so however, recent studies found that genotyping of CYP2C19 doesn't adequately predict response. So that's what we are trying to investigate. So we are going to look at pharmacometabonomics. It's a discipline of metabolomics which focuses on identifying metabolic fingerprinting, which can predict or explain drug effect or toxicity. Like Prof. Hani Arifin mentioned just now, sometimes the genotype is not really translated into the phenotype. Okay, so we are actually looking at the actual phenotype, which is the metabolites, and see whether we can use that to predict the drug response. So this is just a general objective to evaluate the use of pharmacometabonomics, pharmacogenetics, and platelet function testing for the personalization of clopidogrel antiplatelet therapy in coronary artery disease pain. So we want to try and compare whether pharmacometabolomics or pharmacogenomics, which one has better predicting availability for the clopidogrel response. So that means before we start a drug, when we look at their metabolites or the genetic profile, are we able to know how the patient is going to respond to that drug? Okay, so that means before we start the treatment, we already can anticipate how the response is going to be, so we can decide whether we want to give the drug, whether we want to change the drug, or whether we want to increase or decrease the dose. Okay, so this is the possible outcome from the study. Okay, and this is just the methodology how we did this, and we collected a pre-dose. That means before we start the drug, we collected their blood sample. Okay, and then we give a loading dose of 600 milligram of clopidogrel. We use the brand Plavix, the original, the innovator drug. Then after 6 hours post loading dose, we took again blood sample to measure the outcome. So we are looking at pharmacogenetics, we are looking at metabolites, and we are also looking at platelet function test. So we look at these three responses. The platelet function test, the purpose is we want to use it to assess the outcome. Okay, so it's more and the outcome to see whether the genetic are associated with the platelet function testing or the metabolites are associated with the platelet function testing. So the outcome of this clopidogrel treatment is how is the platelet function testing. Okay, so of course there are mechanisms how to do this. There will be centrifuge. There are methods to do genetics. There are methods to do metabolomics. Today I'm not going to focus the detail of it. For the platelet function testing, we use a standard kit called as Verify Now VN P2Y12 kit. Okay, so which can actually measure how active is the platelet. These are genotyping methods. So we extracted, we took the blood, we did the DNA extraction, okay, and then we look at the PCR. We try to identify the we did sequencing. We try to identify the variant or the wild type of CYP2C19 only. Okay. And for metabolomics, again, we take the blood sample, we centrifuge, we take out the plasma. We also did urine, but I'm not focusing that. Sorry, I'm also focusing on urine for this presentation. Okay, plasma and urine. Then we put in we use NMR to do the metabolomics to identify the compounds. And then there are some statistical analysis where we can actually identify what metabolites present in that blood and urine or plasma and urine. So we screened 9,940 patients going for IAP procedure. Patients were screened. So patients are going for angiography. We screened them. And then we selected the patients who are eligible based on our inclusion-exclusion criteria. Okay, there are 364 patients who are eligible. So from there, we recruited 89 patients for genotyping. And then we got results for platelet function testing. We only got results for 71 patients. So overall, these are the results for pharmacogenetics. We found that about 40%. Okay? If you can see here, the wild type in purple color is about 40%, and we see the heterogeneous allele for CYP2C19 we found about 40%, and also the homozygous is about 16%, which means about 60% of the patients are having a variant type of allele for STAR2. Okay. But for STAR3, majority 93% are wild type, about 7% are variant type. Okay, so that means actually in Malaysia there are quite a high number of patients who have variant type for STAR2 allele. So that means when we give clopidogrel, we should be aware of this treatment, of this genetics. Sorry. And we also compare among the ethnicity, Malays, Chinese, and Indian to see the difference. So we can see for Malays, it's about 40-40 and about 70% wild type, and then the variant type, heterozygous and homozygous. But in Chinese, there are more variant type. Okay, so it's about 56% which are variant type compared to 33% which are wild type. For Indians, majority are wild type. There are about 40%, 48% which are variant type. Okay, so that means when they have variant type, we should be aware that they may have less response to clopidogrel compared to those with wild type. Okay, this is our demographics. Okay, I think I'm not going to go through this. Okay, so this platelet function test. Okay, so from all these 71 patients, we did platelet function test to see how many actually have still having high platelet reactivity after giving clopidogrel. That means after we have given the loading dose of clopidogrel, and then we measure platelet function test. So there are still some patients still have platelet reactivity, high platelet reactivity. So that means they are still prone to blood clot. Okay, so we found that 60% responsive. So about 38%, about 40%. Do not have sufficient efficacy of clopidogrel, or just do not have sufficient response to clopidogrel. So that means these patients may still have blood clot even though you have given the clopidogrel. Okay, this is among the ethnicity. Okay, so about 30 to 40%. Okay, Malays, Chinese, and Indians. they are still having a high platelet reactivity even after starting the clopidogrel. That means they are still prone to blood clot. Okay, so then when we associate the genotype, we want to see whether the genotype are related to the platelet function testing. Then we found there's a significant results. Okay, I will look at the. Okay, so that means the genetic are significantly associated with the platelet function testing. That means when they are having especially those with homozygous STAR2, they have more significant value compared to the heterozygous. Okay, so if patients carry out the homozygous mutation STAR2, it will be of limited clinical personalized therapy based on genotype. Okay, and then when we look at the metabolomics data, okay, so these are the steps. Okay, we take the data and we did some PLS-DA tests, and then we did univariate logistic regression and multivariate logistic regression. So from the plasma, we found that this metabolomics can predict about 68%. Okay, it's not very high prediction. Okay, but we can see that about 68% we are able to predict the platelet function test. So that means when we look at the metabolites, the compounds, we are able to say only about 68% whether patient will have high platelet reactivity after taking the clopidogrel. Okay. So we look at the compound which are actually related. So we found this region are the ones significantly associated with the platelet reactivity. Okay, so I think I will mention what compound is there. So we did the same thing with the urine. Okay, I will just show the compounds. So these are the regions that we found from the NMR spectra. These are the regions which are able to predict the clopidogrel response, whether patients are going to have active platelet reactivity or reduced platelet reactivity after giving the clopidogrel. Okay, so this is the integrative model. Compounds. So the compound and glycerol 3-phosphorcholine. So these two compounds in the plasma samples are able to predict whether patients are going to have high platelet reactivity or low platelet reactivity after giving the clopidogrel. That means before when we want to start a treatment to patients, we can do a metabolomics. We can look at this compound and we may be able to predict whether patients may respond to clopidogrel or they may not respond. Okay. And in urine, we found this phenylacetyl glycine and also L-proline, which are also able to predict the clopidogrel response. Okay, so the study indicated high frequency of clopidogrel high platelet reactivity among patients undergoing treatment. So we found about 60%, up to 60% of possible clopidogrel less responsive. Okay, and Pharmacometabonomics did not only discount all biomarkers of clopidogrel response, but also reveal conditions potentially associated with it. Okay, I did not discuss the detail, but those compounds we have tried to see how they may be related to the platelet reactivity and clopidogrel, and we found those compounds have some connections with the how the platelet aggregates. Okay, and verify now kit can be useful to assess platelet function test in clopidogrel patients. However, hematological variables should be considered while interpreting the results. So the study indicated high frequency of intermediate and poor metabolizers of C290 in Malaysian population, which may interfere with the metabolism of drugs. So again, in Malaysia, we found there are high platelet reactivity even after giving clopidogrel for many patients, about 40%. And genotyping of C290 might be off limited usually in the personalization of clopidogrel therapy unless the patient is carrier of homozygous. So what we found is when they're having a heterozygous variants, star1, star2, or star1, star3, they are not significantly associated with the genetic, with the platelet function test. Okay? But if they have homozygous star2, star2, or homozygous star3, star3, then they are significantly associated with the platelet function testing. Okay? So that's why we did metabolomics, and even metabolomics we only found about 68%, but at least there's a promising that it can be used. Okay? And we also did the further step. We tried to combine both the genetics and metabolomics. We call as integrative, and we found about 70 to 80% we are able to predict the clopidogrel response. So in future, we are expecting to do an integration of genetics data and metabolomics data, which means the genotype and the phenotypes combined in a model, and we may be able to predict better the outcome of a drug or even a disease. Okay, that's all my talk. Thank you very much. So, any questions?
Yeah, thank you, Prof. I think it was a very good session, giving an overview of metabolomics and how it can help us in precision medicine. So we'll open the session for any Q&A session. I would like to ask if there's any questions on the floor.
Maybe it's still new for everyone, but if anyone
has
any questions, you can always come and find me, and then I can explain more detail.
Yep, certainly. I think that would be a nice. So if there's no questions, you can always reach out to Prof. Bahar and discuss about it. So if there's no question, I think we can close the session. Yeah, so there's a question already that in the chat box. Any suggestion on the use of aspirin, Prof. Bahar?
Sorry, what's the question? Any
suggestions on the use of aspirin?
Aspirin.
Maybe.
Aspirin is already a treatment for coronary artery disease. Okay, but now you can also give dual antiplatelet therapy, especially those who go for angiogram stenting. You should give dual antiplatelet treatment. Okay, so that means you must combine aspirin with clopidogrel. We also did the same study for aspirin because there are also some patients may not respond to aspirin. They are also called as aspirin resistance. Okay, we also did a study on that. It's possible patient may also have aspirin resistance. Okay? But the practice here, this is dual antiplatelet therapy. So aspirin will combine with clopidogrel. For these patients, just for your information, the patients are already on aspirin. Okay, so we only added the clopidogrel, and we still see that the platelet function testing is still not sufficient. The drugs still did not reduce the platelet function activity, not fully. So that means patients are still prone to have myocardial infarction or stroke because the drug is not fully working. I hope I answered the question.
Yeah. Thank you, Prof. Bahar. Okay, any other questions before we sign? All right, I think, Prof, there are no further questions, but you can always email to Prof. Bahar and inquire about metabonomics and see if there's anything that you can help with precision medicine in general. So with that, Prof. Bahar, any last words before we sign off?
No, just want to thank again for the opportunity. Nice to meet all of you. Yep, that's all.
All right. So thank you everyone for joining for this morning session. We hope that you had a good session, and we wish you all the best for the day. Have a good day ahead, and see you soon.
Thank you. Bye-bye. Assalamualaikum.